Good morning, everyone. It's great to be here, and I particularly want to thank Will and Lori and team for putting together what is more than a conference. It's really a gathering of the smartest people to talk about the present and future of health information exchange. And I was recalling with somebody last night the wonderful panel that Wes Rochelle hosted last year, where he essentially invited all of us to participate in the hardest questions he was asking about. And I consider Wes one of the people who both asks the hardest questions and has the best answers. So if you want that kind of dialogue, this is the place to be. So thank you so much. And it's actually really fun to be here on the second day because I can look around the room and think about the personal stories and the successes I've heard about, including the most fascinating account of Will Ross's career. If you have any questions about Will Ross's career, please go ask him because it's amazing. So again, I'm Claudia Williams. I'm the director of the State Health Information Exchange Program at ONC. I've been there for the last couple of years. You probably have met other members of the team. We're going gangbusters thanks to the work that you're doing and having a blast as well. So glad to be here. I'm just doing my little Apple. So I think others said it yesterday, and I'll just repeat it, that we're not here for health IT. We're here for health improvement, we're here for population health, and we're here to reduce costs. These are the triple aims that are the cornerstone, not just of the national quality strategy, but frankly of everything we do at HHS and at ONC. And this is what we're all here for, and this is the passion we bring. And it's always, those words become a little abstract until we think about our loved ones and our friends. And this is, some of you may know him, Dave DeBronkart, otherwise known as ePatient Dave. And thanks to information-rich healthcare, including incredible work he did on his own to make sure he got the best care, he was able to dance at his daughter's wedding, which was an incredible thing. So we are here so we can dance at our children's weddings, and others that we love can as well. So as we think about health information exchange at ONC and our role in promoting it, there isn't one model. And arguments and discussions that try to say this one's the best or that one's the best or let's just do it that way, I think are futile. We need different forms. We need an ability to cheaply and accurately send information to support results and referrals and transitions and labs and things like that. We also need access to more longitudinal patient data, especially in emergent situations. And patients, often, whether we like it or not, are in the position of coordinating their own care, and they need access to their own information to be able to share it and reshare it, but also to enable all the amazing behavior change capabilities that we'll have through apps and tools and other things. So there isn't one model, there are multiple models. We need to advance the ball on all fronts. And what's exciting is, in many cases, the things we need to do for one are the things that will help for the other. So it's exciting to me when I go out there to see examples of all three of these thriving and succeeding. And each of these has its own challenges and frustrations that we'll be talking about as well. Our approach is to remember that we're never gonna get to interoperability. It will be a constantly evolving target, and we'll be making progress along the way. So we need to keep in mind that this is a journey, that we have to solve the problem that lies right in front of us, and then solve the next one, and then solve the next one, and that's just what progress looks like. That we, especially at ONC, have a really unique ability to leverage government as platform, to take on some of the hardest problems, and to collaboratively with all of you solve them. And I think states excitingly have that same opportunity to be the place where people come together and solve problems. That, as I said before, there is no one-size-fits-all approach to health information exchange. And that's both from a model standpoint, it's also from a business model standpoint. And that I think productively to avoid conversations where people are trying to battle among the models and just really look for the things that are going to make progress clear and rapid across all of them. And that we will build in incremental steps. This is the way change happens. We take one step forward. We just need to make sure that the things we're doing, as Sean Nolan said yesterday, are those things that create this exciting ripple of effects on the edges and in the middle. So let's focus on the right things that will enable the most progress. You know, there was a period in ONC's life, and I think interestingly in the life of Markle and others, where there was a lot of focus on coming up with the right architecture. You know, if you remember the early NHIN demonstrations where folks were like, let's just come up with the right one. You know, let's have that architecture discussion. And I think it's because people were trying to imagine this new world. Will told this great story last night where John Halamka and I can't remember, Mark Overheege and others came up with this framework of RLS and other things, and Will implemented it. And they said, you did what? He said, yeah, I implemented. I implemented what you came up with. And I think in that year, that's where we were. We were trying to imagine what this could look like. But now, and if I think about ONC's role, our role is not to come up with a single architecture. Our role is not to come up with a structure that everyone will use. And instead, it's to find ways to use policy and standards to enable exchange, assure trust, and to lower the cost of exchange. It's a messy world out there. It's going to have the characteristics of internet growth, where things were happening we didn't even know about using the tools we put out there. We don't control it. But we, by focusing on the right things, can lower cost, can assure trust, and can increase interoperability. And that's incredibly exciting. It's a little challenging sometimes when you're not in control, though, because folks say, well, when's it going to happen? When are we going to have a network to plug into? And especially with the Hill, with Congress, when's it going to happen? And we really believe this is the right path, and it has already shown incredible results. But it's a lot easier when you're just in control. But we try not to pretend we can, because we can't. With the kind of scale of change we're talking about, it's a matter of enabling and allowing and getting things moving in the right direction and not control. So things don't look so hot. I mean, these data are a little old, I admit. But what they show is that 3/4 of it, this is an international survey that the Commonwealth funded in 2010. They're about to put out their new results. But 3/4 of the time, PCPs don't get discharge information within 2 days. So imagine a CHF patient discharged to home with the doctor not knowing they've been discharged to home and being at risk of readmission within that 2-day period, right? So, and only 19% of hospitals in the HIE survey report that they're sharing clinical information electronically. And I don't cite these numbers to get depressed, but to remind us that we have a long ways to go and we are on that path. But when you look at how often patients' transitions and patients' lives of care are supported by the right information at the right time, it's not happening. We also know that the costs of exchange are far too high. Interfaces often cost. I talked to some hospitals who say, well, I have 10 different systems. Every single interface costs me $10,000 each and every time. And it doesn't matter that it was already done twice over here in the next community. The costs are high. But we're seeing this burgeoning of exchange activity, both in the public and in the private sector. And what's so exciting is that's being driven by the realization that payment is changing, that fee-for-service is not here to stay, that folks are going to be accountable for quality and cost. It may not happen tomorrow. I may not be an ACO this year, but the trend is there and it's happening, and that's really driving a lot of change in the health delivery market, including the realization that exchange is critically important. So we're in this environment where there's a lot of opportunity for improvement, and there's a great deal of interest in making rapid change. Now, let's think about the curve we want to see. We want to see a hockey stick curve, and let's look at the curves we're already seeing in health IT. So this is the e-prescribing users using the SureScripts network, and today we have 45% of providers e-prescribing. The vast majority are on electronic health records. But look at where it started. It's just like anything, it started low, and it was kind of flat for a little while. And then it took off. And actually where the slope changed its shape was HITECH. It took off. And today, I think, there's still complaints, there's still issues. Some patients don't want e-prescribing, but I think we think of it as the way prescribing should occur. A tipping point has occurred. Likewise, these are the NCHS data that were released a little while ago about EHR adoption. And these are the curves representing the different age groups. Now, you'll notice that older folks have much lower adoption, as we all know, than younger folks. But look at the shape of the curve. It's the same for everyone. And look how it's going up. Again, tipping point has occurred. 57% of office-based physicians are now using EHRs. And I think we've reached the point where we're no longer arguing about whether this is whether we should do it or shouldn't do it. Can we wait, can we not? It's assumed that this is the way care is going to be delivered. So these are the curves we're trying to create with health information exchange. And there's as much to do with the expectation of what good care looks like as it has to do with the technology or even the policy. And we need to shift our expectations such that not having information and not delivering care with the information that's available is not acceptable. It is not acceptable to patients. It shouldn't be acceptable to providers. It shouldn't be acceptable to vendors either. The last graph I'll show, and this reflects some of the data that we saw yesterday on California, are the payments made under meaningful use. And remember at the beginning of meaningful use, and folks were talking about PQRS, and they were saying, remember how we submitted our thing and we never got paid? It took me 2 years. We still don't know if we passed or we didn't pass. 133,000, more than 133,000 providers have been paid under meaningful use, both hospitals and doctors. And almost about half of all hospitals have been paid. So adoption's going up for e-prescribing, for EHRs. The dollars are going out the door. We have seen a tipping point. So how are we going to create the same pattern with health information exchange? So I'm going to talk about things that ONC is doing. But I invite all of you to make this the year when we turn the corner. Because it's not going to happen without our shifting expectations. It's not going to happen without asking whether our business model really supports this or doesn't. It's not going to happen without adopting technology that works to make it happen. It's not going to happen without helping docs and patients who may find it baffling or concerning. So we need all of you to make this happen, to create a hockey stick this year. And here's just a graph from one of our state health information exchange partners, Nebraska. So here's what they were able to do in 2 years in terms of the number of users of their exchange services. So I'll focus today in the remarks on sort of 4 thrusts of activity at ONC, and also hopefully have lots of time at the end for questions, because there's a lot going on, and you may have questions about things that I don't talk about, and I may or may not know the answers, so we'll have lots of time at the end. Well, we're going to talk about stage 2. Now, I know you don't know what's in stage 2 for sure, but we're going to talk about proposed stage 2 as a sort of benchmark of what we should be thinking about. We're going to talk about the standards building blocks that are in place, actions to advance all 3 forms of exchange, and the State HIE Program. So I don't think anyone can look at this graphic without, at least I can't, without thinking about meaningful use, because this is sort of the swoosh that we all think about. I remember David Blumenthal kind of putting it up there. And I remember when we were at that first stage, it's like, really? It's about data capture? Okay. I can't get too excited about that. But now we're starting to see the benefits of that. So in stage 2, what we're focusing on is HIE and care coordination, and really making sure that those standards building blocks, the vocabularies and the content are robust and there to be sure that when information is shared, it means something. And in stage, the irony of this, it reminds me of the federal budgeting process. We're starting the conversations about stage 3. So we've had our first work group meetings on health information exchange requirements for stage 3. And it's a little frustrating for the members because they don't know what's in stage 2 yet. But we're going to have to drive ahead quickly on stage 3, and that's one of the things I'd like to talk to you about. But this middle phase is about those improved care processes and health information exchange. So I just wanted to highlight for you a couple of the requirements that were in the proposed rule. One, that a summary of care document is shared for 65% of patients, but that doesn't require electronic transmission. But for 10%, it's sent electronically. Now, you could say that 10% is low, and it is, and many of you wrote in and said it should be even lower or shouldn't be a threshold. But what that does is creates the expectation and the requirement that everyone be able to do that. That if I send a patient, okay, and if I'm going to do it for 10%, guess what? I'm going to do it for everybody. Doesn't matter. So this relies on the basic core standards that are in stage 2 meaningful use, the consolidated CDA for the content, direct transport protocols, as well as the NW exchange ones for those who want to use them for the transport. Okay, secondly, patients can view, download, or transmit. Now let's think about this. So every EHR has to allow me to be able to view my information, blue button it, or transmit it to the source that I want. And in the proposed rules, providers were held accountable for that. And we heard from a lot of folks saying, I'm not comfortable with that. I'm not comfortable being held accountable for actions that my patients take. But as we talked to folks who have implemented, they said, you know what? Actually, we as providers have a huge ability to make this inviting and interesting and enticing to patients. So this is an invitation to patients to participate. And if there's a level of accountability, even if it's small, it's going to allow us to embrace that concept. Because otherwise, there's so much stuff to do. There's a lot to do, and it's going to be hard to make this a priority. So as we think about these requirements of view, download, transmit, there are ways to see all of these requirements as check the box. But I invite you to see them for this potential that they have. Wow, I could refer a patient and send the information to any other doctor electronically and securely in a way that they could consume it into their EHR. Wow. I, as a patient, can embrace being able to have my own information and do what I want with it. Maybe I want to combine it with my tracking information. Maybe I want to share it with another doctor because I want a second opinion. Maybe I want my daughter to see it. Wow. There's magic in these requirements. And there's also pain. But I invite you to see the magic and communicate that to other people. And finally, there are submission requirements, much more robust for public health, immunizations, and so forth. So as we look at both stage 1 and proposed stage 2, and think about interoperability, I mean, they're different. There's the interface questions, but core to interoperability is that information can have the same meaning by me and by you. And for that, we need standards for the vocabularies and the content. And I know John Halamka had this fabulous blog post. He got so, and at the standards committee meeting, he was like, we are driving towards a single standard for every concept. We weren't ready for that in stage 1. If you remember, we had options for different standards then. And the role of the federal government should not be to settle battles that haven't been settled in the market. But our role can be to name standards that have already seen widespread adoption, drive them forward, and have them support the interoperability that we all want and need. I spent a couple days in San Francisco largely talking to startup companies. Now, many of them have a very vague understanding of meaningful use. And part of what I was trying to do is say, you actually have an opportunity here you may not realize. Because when we ask them, what are the things that would make your tools really work and really grow and really be possible, they said 2 things. They said data liquidity from EHRs, and they said standards so that we can code and know what we're getting and enable the kind of innovations that we'd really like to build on. They said that without realizing that those things are both going to be enabled through meaningful use. So there's a huge opportunity for innovators and tech developers and Health 2.0 folks, in addition to the other health IT vendors that we're talking about. Also in Stage 2 proposed rules, there were two transport standards identified, both the direct standard, NWHI and direct, as well as a portion of the exchange standards for transport. And finally, more highly specified standards both for the content for transitions as well as lab. So interoperability is a journey. This isn't all the way we want to go, but these are big strides forward that will enable a lot of innovation and change in health information exchange. So in addition to these core pieces of work around Stage 2 and standards, there also are some important specific projects that we're embarking on related to all three forms of exchange. Now, I think we saw this graph before, maybe, I think from Sean. More than 30 states have now deployed direct services. And we see the total directed exchange transactions in Q1 as being about 53 million. Now, these aren't all using direct. Some of them are lab results or public health results that aren't using direct. But it gives you a sense of the scale of what's being enabled just by our grantees. Obviously, there's a lot of other activity in the private sector and in other HIE forms and in many of you who have launched your own networks. But this gives you a sense of the scale and progress that we've made in the HIE program. So as we've started really talking and seeing what's happening among our grantees using direct, we've noticed a couple patterns. One is that largely the vendors that are available today are not the EHR vendors. The EHRs are actually, vendors are showing great interest in deploying direct, either integrated fully into their system or using a separate HISP. But today, it's largely standalone vendors. So the workflow we're talking about is a doc needing to leave their EHR workflow, go on over to a portal, send a CCD, and come on back. And we know how well that works. So while it provides a really fabulous replacement for some of the current methods of sharing information, it's not the integrated, workflow-friendly kind of implementation that we saw. I don't know if I actually missed John Blair's presentation, but the MedAllies work is amazing in Hudson Valley, whereas a doctor can say, what do I want to send to the cardiologist? And how do I make sure that I get the information back and stay within my EHR workflow? So this project, 360X, which is being led by Paul Tootin on my team, has a straightforward goal. It assumes that we have we have direct and we have certificate discovery for the certificates, but the pieces that's been missing so far is the integration into the EHR workflow. Now you might say, one of the things we've done at ONC is we've said, we're not gonna look inside the box. We're gonna deal with the things that lie at the interface of your EHR and others in terms of our exchange work. But here's an example where we want everyone to do this, and we may wanna have a common understanding of what the ideal clinical workflow might look like, and you're gonna implement that incredibly differently in Allscripts or NextGen or Athena. So we're not asking everyone to have the same implementation, but we are saying, wouldn't it be cool if there was workflow in every EHR that allowed you to send a referral, picking the information you wanted to send, using a consolidated CDA, and using direct for transport, so that this implementation could be the way that people move forward with Stage 2. And we already have an incredible number of vendors. This was launched last week, and we have really incredible participation from all the nations, or almost all the nations, leading EHR vendors and other HIT vendors. In addition, one of the other things we were noticing, so a big part of what we work on is like kind of doing something, and then it's sort of like the PDSA cycle. You do something and you're like, how's that working out there? And some of it's working and some of it's not working. So one of the other things that was challenging, I think David Kibbe really referred to yesterday, we were seeing a lot of HISPs deploying direct in a closed network. So not using DNS for discovery, and essentially what that meant is that if I used XYZ service, I could really only send a direct message to somebody on that same service. And that really isn't the vision we had when we started. The vision was that everyone could deploy it and you could send to anyone using another service. And what we've realized is that it's not a huge lift, but there are some important trust requirements that are needed as an additional layer to direct. And I remember Arian blogged about this, I believe, right as he was leaving the ONC team, and he said, who knew that the challenge we were going to have to grapple with was scalable trust? But that wasn't a challenge you could deal with first. First, you had to show that this would work. But now we're in the middle of this question of scalable trust, and I know this is something that folks in California have been working really hard on. So basically, the HIE program put out a set of guidelines for HIE grantees that lay out policies, requirements around implementing the applicability statement for direct, thoughts on how to manage certificates, authentication of end users, with the idea that if we kind of follow a similar pattern of requirements, we can much more easily get to scalable trust without requiring one-to-one agreements between everyone, which I think is just an untenable solution for nationwide scale adoption. So this is really exciting. We're looking, we just put it out. It is something we put out not in the form of like, you must do this, but more like, guys, this is gonna help. Like, let's get going, this is gonna help. And we're both excited to see it implemented and also would love feedback. And I know I've talked to David Kibbe and others at Direct Trust, as have members of my team, about how to, are these things that can also be accommodated there and worked into the certification program as it goes forward. And I will also note that many of the ideas in here actually came out of the direct community and came out of the work that Direct Trust has done. So here's another example where you all are doing the work, but we do have some tools at ONC to recognize that progress and nudge it along by pointing at problems and solutions as we go forward. So in addition to directed exchange, which serves a super important purpose in terms of care coordination, we also have a lot of work in the HIE program on query-based exchange. I'll show you in a little bit the states that we have already deployed. But we also have a lot of grantees that are planning to move into this space over the next year. Many of them had phased programs where the first phase focused more on directed exchange and the second would move towards query. They are lucky because they've gotten to benefit from the experience of all of you, of some of the failures that we've seen in the market and some of the successes. And so some of the lessons that they're taking away as they move forward are, first of all, that this has to be in service to people using it and meet their needs. They will be the ones paying for it. So yeah, a business model has to be formed around them, but more importantly, this has to meet, they're at the center of this. So you can't create some made up model where you're just assuming everyone's gonna come participate. You have to start with that fire in the belly, but often also the ability to work across different groups who may not see things the same way. And this is different from indirected exchange, remember. Because in directed exchange, people can act separately and enable things on their own, and it still enables exchange. But with query, you need to agree on things in advance together. You need to know what your policies are for accessing information. Those decisions have to be pre-coordinated. So it requires a very different kind of implementation than we're seeing with some of the other use cases. Also, it's exciting to see the opportunity to be incremental and build on the progress that you might have already made. So an example would be in Rhode Island, where they're using the direct protocol and triggers that exist within EHRs to trigger the creation of a care summary that would populate their exchange. So again, using what you already got to build to the next layer that you might want. Equally, we're seeing folks who are interested in doing things like alerting services when someone hits an ED that might use an ADT feed you already have and an EMPI or a provider directory you're creating. So these are the states that have already deployed direct service. And the way we measured that is we actually ask for a reporting of transactions. So these are the states that reported transactions in Q1. And the total number of transactions by our HIE grantees was about 2 million. So you can see also that difference in scale where directed exchange transactions was about 52, this is about 2. I'm not exactly sure where the proportions are going to end up lying, but I think we're going to, just the results delivery kind of thing is really the meat and potatoes of care delivery. Query provides a really important function, but we'll probably see a lower use rate like this. So in terms of that third model of patient-mediated exchange and thinking about meaningful use stage 2, and again, thinking about the magic that we can create. So as part of the magic we can create, which would be really exciting, is that view, download, transmit becomes a way for me to say, send all my information over there. Not make me go in every time and push a button, but just send it all over there. Well, how are we going to do that? Well, if you think about what's already in stage 2, where you have transport, you have a content standard, the consolidated CDA. What if you added in a trigger where every time an office visit closed, a care summary was created and sent over to whatever PHR or other endpoint I wanted? And what if we worked out the policy requirements for making that happen? And what if we could say to docs, hey, an easy way to satisfy this requirement is letting, maybe they will want a portal, maybe they won't, but this will be a way that patients can actually pull their information from all of their different providers. So we are standing up a new S&I initiative. Some of you were at a meeting in DC where we talked about this, which is going to enable set it and forget it functionality for Blue Button. And I'm also really excited to say that we are one of 16 projects across all of federal government that is going to benefit from having a Presidential Innovation Fellow. And this fellow will be working on this initiative. So that's really exciting. Last, I wanted to talk, I've been threading conversation a little bit about the State HIE program throughout, but I wanted to just talk more explicitly and remind us what this program is all about. It's all about enabling meaningful use for providers and doing it in a way that makes rapid progress. We're not talking about building something that's going to bear fruit in 5 years. We hope we will build things that bear fruit in 5 years, but we need to make rapid progress to support providers today. We're talking about building on private sector investments. So if folks are doing exchange services, but there's something missing that the government can supply, that's a really viable strategy. And recognizing that every state is different, there's not going to be a cookie-cutter approach to this program. So these are the sort of core principles and attributes that we bring to this program. And I know California and many of their work mirrors these concepts and mirrors these ideas in their strategies. So here's some of the specific kind of tactics we're seeing to get to these goals. So in particular, we're seeing a lot of focus on directed exchange as a way to get to the white space, especially as community level exchanges or private exchanges are developing. We're also seeing a lot of focus on investing in that boots on the ground support for docs, for small labs, and for others that may not have the capacity to participate as robustly as in exchange as some others. So Indiana, for instance, is using this approach, giving mini grants to some of those kinds of providers. And also we're seeing the emergence of efforts to assure that kind of scalable trust, like in Rhode Island with the trust communities. So we have a common set of requirements. We're seeing a variety of really exciting tactics to get the job done. So I want to close with 2 things. First of all, we have a number of issues that we need your help with. And I'm just going to briefly mention these, but I'd love to focus some of the discussion on them. We need to make workflow, especially for care coordination, really work easily and well for docs. And that's a challenge for every single approach that I've seen to information exchange. It should just work. Patient matching continues to be of grave concern to hospitals and to others and raises safety problems. And there's a lot of dialogue and debate about this. And we need solutions to make it safer. We are seeing the emergence of incredible activity among private exchanges, so-called private exchanges. We need those to be standards-based, and we need those to connect to each other. It's exciting that that's going on, but those cannot become walled gardens. So there's policy as well as technical issues there. And as information trickles, become flows, become floods, we're going to have problems of abundance, not scarcity. And we're going to have much better ways to filter information, present information that's of highest quality and most accurate, give docs tools to sort through it. And we're at the beginning stages, I think, of that challenge. It's a as Clay Shirky says, that's a first world problem, but it's one that we'll have soon. We're going to need to have a way of thinking about health IT for ACOs and other integrated delivery, where the EHR is a critical component, but not the only one. So the EHR is going to need to play nicely in that environment and play the role often of being the critical workflow piece, but it's going to need to be able to communicate with analytics engines, with apps and tools, with data layers that can be available for query. So we're going to have a more holistic way of thinking about health IT. And I think there are a lot of cases. Interoperability is a huge issue that needs to be tackled. But sometimes we're not really talking about interoperability. We're talking about business interests. And let's call a spade a spade. If folks aren't implementing what they're doing in a way where they can share across systems, that's not because we don't have standards, always. It's often because that's not in their business interests. And we need to challenge that, and we need to reward and recognize businesses that are taking a different stance and that are benefiting themselves and others through the sharing of information appropriately and securely. And finally, there are going to be a new set of liability issues. Some of them might actually look to be beneficial to what we're doing by saying, if you don't consult information that's available, hey, that's a problem. But there are also issues of what if you rely on information that's inaccurate and it wasn't information you collected. So there's a whole host of liability issues that are going to need to be grappled with. And I would just love your feedback and thoughts about all of this. Okay, true confession. I wasn't planning to share this, but this was a paper my husband wrote, but I thought it was terrific. But it was basically trying to take what we learned from the internet and applying it to how we can go about doing our work. Now, he was thinking about this in terms of government and nonprofits, but I think it has some interesting applicability to all of us. So I just want to share a couple of these. One is talk about what you're doing while you're doing it. And I think if I think back to some of the things that were most exciting about the Direct project, there were two things. I mean, many things, but one was that everything was out in the open in the wiki. And I know what I heard is that when people started emailing each other, Arian would say, absolutely not, do it on the wiki, right? We do not want offline conversations. We're going to do this out in the open. If it doesn't work, that's going to be out in the open, because then somebody might be able to solve it for us. So the more open we can be about what we're learning and what we're doing and how we're succeeding and how we're failing, and we all have ways we can do this. For some people, it will be blogging and wikis, but for other people, it can just be coming up on podiums like this and saying, I tried this, it didn't work. I'd love your help. Second, create simple systems that work. And this is known as Gale's Law. And it says that a complex system that works is invariably found to have evolved from a simple system that worked. And this is a closely tied concept to the concept of modularity. But I think when Sean was talking yesterday about, look at all the surprising stuff that's happening through this simple thing. Think about the @ sign. Think about a URL, HTML, and these things that have created a hash sign in Twitter, right? So as we think about deploying our work, it's good to remember and think about, what is the distinct problem I'm trying to solve right here, and how can I do it in a way that will open up new possibility for me and for others as we move forward? And then in the last one, I want to reflect is we're trying to create internet scale change. And we're trying to do it through the kind of hockey stick curve that I showed you earlier. We're gonna do that partly by probably thinking, well, what's the new business model that might be more open, that might be more network-based, where maybe I'm getting pennies on the transaction, but I have millions of participants. How do we think about creating that kind of momentum in what we're doing and asking ourselves if the things we're doing do enable that kind of change? Because that's what we're here for. We're here for Dave DeBroncart so he can be at his daughter's wedding. So thank you a lot, and I will close by, I don't know, maybe I'll stay at the podium, but I would just love your thoughts, comments, questions. Don't feel like you have to keep it to what I've talked about, but I will certainly tell you if I don't know the answer. But please feel free to comment. It doesn't have to be a question. Thank you.
Great. Thank you, Claudia. And I know there are going to be a number of questions, but since I'm the moderator, I get to go first. One of the things that you mentioned in your slides was this movement in stage 2, really focusing on the patient, sharing data with the patient, moving data out, personal health record. One of the things that we saw on, I think, John Blair's report card yesterday, I don't know if you all saw this, but there was lots of reds in the category of giving out the clinical summaries. And that, from my perspective, is a huge problem. For most of the doctors, at least that I've been working with, they tell me the patient doesn't want the clinical summary. They have a piece of paper and they have a shredder. And so they're pushing the print button so they can pass the meaningful use, and then they're tossing the stuff in the shredder. What are some of the, now this is increasing, what are some of the thoughts around creating that opportunity to explain why the patient needs that piece of paper?
Well, what's exciting about stage 2 is you don't have to get a piece of paper. I'm healthy. I rarely go to the doctor. I'm lucky. I don't have a PHR. I just got doctors with EHRs. But if you said to me, hey, would you want all your information to go here? Would I say yes? Of course I'd say yes. But if you give me a piece of paper, what will I do with it? I'll shred it or I'll put it. So I think the potential, if we just we need to make this super easy for both docs and patients. We need to decrease any kind of tension and sand that's in the gears. And I think we need to also probably help give patients the ways to have that conversation that are easy, because I think it can be very difficult. We heard from Lance Armstrong that he wouldn't feel comfortable asking for his own information. I think in stage 1, giving somebody a piece of paper, I may not feel great. I may not be in a position to be able to do anything with that. But I know, and John and others from Kaiser can talk about it, when they've looked at some of the functionalities that are most used within their PHR, it's looking at the discharge summary information 2 days later when they're at home, or a day later. So we need to give people the ability to make a decision later about how they want to use the information. I think we need to really reduce the friction and the costs and that. But I think we're in the middle of a game change here. So my feeling is that we're going to have a lot of unlocked potential from that kind of data liquidity, but we're at the beginning stages of it.
Laura, question?
Well, first a comment. One of the things that I bet you don't hear a lot is thank you. Thank you, ONC. Thank you, Claudia Williams and Farzad, for the leadership that you show in, system change is hard. And it's messy, and it's creative, and it's chaotic, and it takes somebody standing up and being the person to be the one willing to take the shots. So thank you for that. But then secondly, one of the things that I am noticing is there is a lot of communication, but somehow the communication doesn't end up at the same point. So there doesn't seem to be a gateway where people can sort through all of the options and kind of, what can we do to help start to create that kind of a document repository or a gate kind of, I have a question about this. Now, California's done some of that, but how could we do that more efficiently and effectively?
This is a big challenge, and I'll never forget Sean's blog post when he said, "Could you just stop doing stuff? Give me a break." So I think a couple layers. I think one thing we have heard a lot. So they're different people, obviously. There's just the doc who's implementing, and we're really trying to drive our website healthit.gov to be a much more effective launching place for a provider into the kinds of documents that would either exist, because that's the other problem is you have CMS resources and you have ONC resources. So we're trying to have that be the landing pad for docs. But there's another layer of folks, which are the folks that I think what's been really exciting is the amount of engagement and collaboration that we've had through S&I initiatives, the policy committee, the standards committee, calls for comments, public meetings, hearings, right? So there's all this opportunity to participate. And what I hear a lot, and I know Janet said this a lot yesterday, is it's just confusing. There's so much stuff going on, and could we help people navigate that a little bit better? I don't have a particular solution to point to, but we are hearing that a lot, and I think it's something we need to think really seriously about from sort of the website and resource standpoint, and also just from our communications out there in the world. So just know that those problems are heard, and we are so grateful to all of you for the collaboration that we have. It's astounding to us, and so thank you for all that you do, and we will try to do better in organizing that so you can make decisions about what to participate in.
Thank you. Dan?
Thank you, Claudia. Appreciate the leadership in the presentation. One of the things that really affected me and gives me courage to face all this change was something called appreciative inquiry, which I know a lot of us have heard about, which basically, a recap again, is that look for things that are working and find the magic that's in there, because there won't be time to analyze everything and document it and figure it out, versus the old problem-solving methodology, which worked in the 60s but is no longer relevant, probably. And I know you have a lot of resources that capture what's working out there. And just wondered if you could reiterate some of those resources for us that help us see, those patterns so that help us adapt to the change and stay in the game.
Sure, and thanks for that. One of our key activities last year was trying to use the book Switch. And for those of you who are at our grantee meeting, we actually had one of the Heath brothers come speak about how to create big change. And often it's based on, even in very impossible situations, finding the glimmer of thing that's working and building from that. That's a very broad question simply because we have so many domains of work, but I'll say in the HIE program, one of the things that we've launched is something called Bright Spots. And we've actually been focusing on one topic every month and doing deep analysis of where we're seeing success and where we're seeing the bright spots. And then analyzing that and putting out documents that are both sort of synthesis documents as well as Buzz blog posts. So usually those end up in the HIT Buzz blog as sort of the summary document. But we are trying very hard to do that. I will say that the thing that makes it challenging is we don't always get bubbled up to us the stories. And that's another reason why if you can tweet about what you're doing, if you can talk about what you're doing, if you can blog about it and get it out there, we want to, like for instance, our grantee in Guam is using Direct to do care coordination with the HIV care coordinators. Now we happen to know about that because they're our grantee and they were reporting it to us. But that could easily have been happening in some small community that we didn't know existed. So we now have the power to be sharing bright spots, all of us, And I don't think we should be assuming that we can play that aggregation role and bring it in, but we need you all to be telling your stories about what's working, so that we can identify that, and not just tweets and blogging and all of that, but also send us emails. We love to hear about it.
One of the other areas you touched on was the personal health record, this transmitting and downloading. Are there thoughts from the ONC about really forcing some more standards around personal health records? Because if each of the hundreds of EHRs create their own PHR that doctor pushes into, now as a patient, I might have 7 PHRs, an Epic one, a Practice Fusion one, a NextGen one. How do we drive that to a PHR that's got all of my information?
So that's the beauty of the transmit part of the VDT requirement, is that if I have 10 or 15 or 20 providers, I could ask that they all share information using standards that are already in Stage 2 to do that. So I think that is a challenge, and I think we do see the need to make that transmit one a really viable option so that folks can indeed assemble their information. There's also a lot of work that's gone, and I'll just point to the Markle Foundation as one example, where they spent a very large investment of time and energy coming up with policy and technology principles for the patient-facing technology space. And certainly when you look at the work that Health Vault and others have done, have driven towards using Postel's law, which is trying to be generous in what you receive, and judicious in what you send. I mean, there's a need to be able to take in very structured data and very unstructured data, but I think we've seen pretty deep adoption of standards by the patient-facing technology, but we need the data liquidity that's coming out of other data stores into those sites. So to me, if I had to place a bet on what to focus on, it would be to really make that data liquidity work and allow patients to be able to make it easy and super cheap to assemble their information, because all kinds of possibilities will be enabled by that. No questions about, somebody has to ask, when's Stage 2 coming out? No? Okay.
Actually, that is a great, that would be one of my
when
questions.
When is Stage 2 coming out?
Can't tell you.
Because
soon.
Because given that it's a room full of HIE people, we are so conscious of all the stimulus that's gone into EHR, and we're so conscious of our many safety net, FQHC, and small and solo physician offices who say, and why should I be doing this? And why should I put more time, effort, cost, complexity into my life right now? I'll wait till 2.0. I'll wait till Stage 2. I'll wait till the incentives come back. But that actually wasn't going to be my question. But yeah, if you can bring that forward, that'd be great, and link us to EHR incentives better, that'd be fabulous. The other thought, though, and this sort of almost isn't fair to ONC given your purview, but we would love to have somebody on a website somewhere give us a simple matrix of, as you say, those bright spots for what's working on sustainability models and on the organizational structure that supports them. A lot of us are inventing that wheel in California, and there's an incredible range of what we started out with versus are starting to try to evolve to. And as we interview people around the country, which is often very difficult to do, to find the right person to talk with, there are just so many different models, but there is starting to be converging evidence. If you guys could take one page to say, here are 4 generic models that have seemed to be working, that would be so fabulous, both for pricing, sustainability, and for the organizational structure that supports. Thank you.
So I'm going to violate the appreciative inquiry here for a minute. And we actually did recently do some analysis of HIEs that have failed. And I know that's an old story. But it was really interesting because I think you notice a couple things that the flip side of which are probably the success factors. So one is having a very big vision and large investment that doesn't deliver results for a long, long time. And what you see is that people's patience and their ability to sustain their support erodes over time. So that was one of the things that we seem to find from the examples was, and so then you're faced with $10 million a year, but you're not going to see results for a long time. I think the other is that the critical importance of building up network effects quickly, because the value of something like an exchange is based on how much information is in there and how many other people are using it. So strategies and tactics that can build network effects and network acceleration quickly are really, really critical. And it's just incredibly good execution and business-mindedness and sharpness and killing things quickly that aren't working, and those kinds of things that you see a lot in more startup environments where you're agile and you leave yourself the room to be able to switch strategies if you need to. So if you're still trying to drive forward on exactly the same strategies 2 years in and haven't given yourself the freedom of motion to make any changes, that's challenging. Now you can see that all of that is made more difficult by contracting relationships where sometimes it's hard to build in those flexibilities at the front end. But I think some of those examples of things that tend to have been factors where things didn't work, you can see what the flip side has to look like for things that do work. I know that doesn't answer your question about sustainability per se, but it's what we've learned.
Will?
Hi, Claudia. Thanks a lot for the presentation. I wondered if you could just take a moment and imagine, this is a greenfield question, blue sky question. What's the post-meaningful use environment look like for health information exchange?
Well, I think if I knew that, I wouldn't be working at ONC. I think the conversation, I'm very passionate about HITECH. I'm very passionate about the programs at ONC, about meaningful use and all of that. But the conversation about health IT and how we're using it to improve care is quickly shifting to the places that are, I'm thinking about John Blair, the places that have pioneer ACOs, the places like in Oregon that are implementing CCOs that are going to get global budgets for Medicaid, places doing health home. And so as we look at the requirements of managing a population of people, some of the things that you quickly see the need for, and I think we saw it on some slides yesterday maybe that Janet had, are team-based care and how you really manage a population of patients across a disparate team. Again, being able to do hotspotting and quickly identifying patients that may be at points where they need interventions, at being able to move not just documents but also clinical decisions, be able to say, I'm sending you a verb, you need to do this, and not just sending you a document. Being able to enable the kind of agile search that we benefit from in Google and other things so we can quickly find documents. What's interesting though is that you start to see that actually when you look at our care delivery system, we don't have the human folks that are working in analytics and care management and know how to integrate and know how to analyze information that are going to be able to avail themselves of the technology to change the care delivery process. So I think we're going to have to be really thoughtful to co-innovate care delivery change and health IT use. And I always get worried when I see, often it's the technology that's ahead of the care delivery, where folks are like, my first move as a pioneer ACO is to buy a big analytics engine. And it's like, really? What are you trying to achieve clinically? And so the more we can do as folks in the HIE space in deeply understanding the clinical goals of the folks that we're working with and using their language and helping them and not selling our solution as something that's distinct from that, I think the better. So I see that as a challenge though, because I'm not sure we're there yet from a capability standpoint in most of our organizations to do that.
Just let me make one quick comment and then I'll let you make yours. I think that's exactly right. And I sort of told this story last night to a couple folks. There's such a contrast when you have that data. In Alberta, Canada, I got to go to a clinic where their dashboard is set up so every morning they have their list of patients they need to follow up with in their diabetes program. They have a nurse practitioner who's on top of that every day. I was at a practice on Monday where I pushed a button and printed a report out of their EHR of their H1N1 candidates. Gave it to the doctor, and she said, "Where'd you get this? Who told you this? How do you have that list of people there?" She was so suspicious, and I said, "It came from your data. I just pushed a button, really." And she looked at it and set it down, and she doesn't know what to do with it. She doesn't have someone to call these folks. She doesn't have someone to check it out. But the power of that data with really one push of a button is phenomenal. So I think in the future, that's where we need to head, is how to use these tools to improve care. Please.
Good morning. Pretty much everyone who has purchased an EHR in the last few years has been told by their vendor that they will be able to support meaningful use objectives through stage 3, which they don't even know what that means yet, which is fine. And they've got that usually built into their contracts as well, saying this is something that we'll be able to do. Given that, and assuming that the EHR vendors are able to accommodate what they've said, what do you see as the role of health information exchange organizations and the state level health information exchange state designated entity in accomplishing meaningful use for those folks? Is there a role for them? If so, what kind of services, functionality should they be offering, and how will the state be able to support that?
Well, I think there's going to be a great diversity. I think in some cases we're going to see EHR vendors that are trying to do kind of all the soup to nuts stuff, including. So let's just stick with meaningful use for a second, and then I'll talk a minute about other payment models. But I think we're also seeing in a lot of cases, for instance, one of the big EHR vendors is saying, we don't actually want to provide direct services, but we're going to do the XDR, XCM and allow a HIS to hook up to us. So then what you're going to need is HIS services externally that can accomplish that. So that's certainly a role for other folks to do that. I also think we're going to see transactions and care processes within meaningful use that could be accomplished by exchange entities. I think public health is certainly one of the primary ones that I think about, but also some of the transitions and analytics and quality reporting kinds of functions. Obviously, if you're using something, if you're just transporting through an exchange, it doesn't necessarily require certification, but if you're doing any kind of transformation, et cetera, it would. So we have already seen in New Mexico, for instance, needed to get certification on the public health lab side. So those modules are going to have to get certified to be able to use by docs. But I also think we need to keep in mind that all of exchange and all of the things that we want and the patient engagement and the analytics, that's not going to be in meaningful use. We'll be enabling that through meaningful use. It's really going to lie in the duals programs and the ACOs and the medical homes and the more advanced care processes that we're seeing. So one of the things that we've been trying to do in stage 3 is be thoughtful in saying, we want all that stuff to happen in the market, but what is it we want to hitch onto an EHR and meaningful use? And what is it where the EHR may need to be in service to something else, like being able to send data easily, having an open API, having that data liquidity out of the EHR. So I think in stage 3 especially, we're going to have to ask really hard questions about what's the role of the EHR versus the role of everything else. I also think that there are going to be multiple models. Not only are there multiple models, like patient-mediated query, but also there are multiple business models. So there are going to be very low-cost HIS services that deliver transactions for a penny on the dime, right? There are going to be models that are doing a ton of analytics, sending quality reports, doing feedback to docs, and they're going to want those services because they're involved in a payment model where they have to improve care. They're going to be community-based HIEs, and they're going to be private HIEs. They're going to be vendors doing this, right? So what I do encourage state HIE grantees to do is say, A, don't unnecessarily put yourself in competition with things that are really working in your market. Do the things that are uniquely sort of gaps, but that actually is a bit in conflict with think in a business-like way and provide valuable business services, et cetera. So there's a tension there that's a real tension. But I think there's a lot of opportunity around public health reporting, quality reporting, and some of those things. But everyone's going to have to think in a very business-like way and a very customer service-oriented way about the services they're offering, I think.
All right. Thank you very much, Claudia. Oh, Rim, do you want one comment?
Okay.
Make it quick.
And let me just say thank you to all of you before Rim talks.
Is that because you're planning on running away?
Depends on what you ask.
No. You and I had talked yesterday a little bit about, some of the things that are going on in the S&I framework, which used to be kind of the nexus of where things were happening. I think if you look at the people, I have to do one plug, the folks that are demonstrating out in the hall, I think show that California gets it. There's some real urgency here that we're adopting some of the things that are happening on the national front. And we want to make sure that we are engaged with what ONC is doing, et cetera. I've seen some increased activity in some of the communities of practice. There's still some stuff going on in the S&I framework. Where is it that you see stakeholders here in California participating to make sure that California doesn't do something on its own, but is really dealing with things at a national level? How do we participate?
So I'll give you my framing and my thinking about kind of the lines that are drawn a little bit. So the S&I framework, where we're trying to specify a standard or name a standard or pick something, that activity occurs there. But I like to think of those as the ingredients that get baked into cakes, and where we're trying to put things together and package maybe different standards and different policies and implementation approaches. The HIE program has taken on some of that work. So for instance, this 360X initiative, we're not really naming new standards, but we're trying to put stuff together in a way that creates an implementation pathway that really works. Likewise, we're working with 6 states to model what sending lab results over direct should look like. We're working with 6 states on consumer-mediated exchange options that, again, might build from the standards. So our work in the HIE program is more focused on getting stuff going implementation-wise that take those standards ingredients and put them together into recipes that really work. I wish I had but that only partly answers the question. I would look, to the extent that you're a State HIE grantee and looking for guidance, I think our program and the project officers and the leadership there has a very broad understanding of what's going on at ONC and is the best to inform it. We try to be as open as we can about signaling everything that we're working on. Obviously, there come times when you're in the middle of rulemaking where you can't do that. But I think we have been pretty transparent about all of the policy development, from governance to stage 2 to some of the new developments in direct. So Rim, that doesn't answer your question, does it? Where's Rim? That doesn't answer your question. I don't know that I have an answer.
Well, and I don't know that
It's sort of a hypothetical.
because there are a lot of stakeholders here that I think really want to get involved, and
Yeah.
not just at what's going on here. And so, first, I guess that's partially a
Okay.
comment to the people in the audience to try to get involved, and I think there just needs to be a good.
Okay. Well, let me make a plug. 360X is our effort to do closed loop referrals. It's a great opportunity. If you have a community that you think might be a good pilot for that, with multiple EHR vendors that are trying to communicate, that would be great. On the S&I initiative side, we have a few really exciting things going on right now. One is Query Health, that's coming up with a standardized way to ask questions of the data and bring back aggregated responses rather than always centralize information. Rich Elmore was running that and recently left, but we're moving into pilots. I don't know if Taha is still here, but including with the CDC and others, and it's very exciting work. We also have an S&I initiative around RESTful API. And that work, I know I talked to Josh Mandel about that, and that work is going on. Also, the ongoing work with I think we've talked about how there's going to be a transition with the NWHN Exchange and with Connect. Those are going to be both moving out into outside of ONC into sort of public-private environments, open environments over the fall. So that's another thing that's going on. I'm looking at John Madison, and who's one of the partners in that work. I would Our Buzz blog is actually a good, we almost always make announcements there. So if you're going to track one thing, I would probably track that. And that usually will announce the new S&I initiatives and other things. And then if there's something interesting, you could either go over to the wiki, the S&I wiki, or just call, email one of us or call one of us. The secret sauce is that every single HHS employee's email address and phone number is publicly posted on the HHS website. So honestly, if you ever get confused, just call one of us and we'll try to help you out.
All right.
I hate to say that, but it's true.
I was going to say, check your email and your phone.
Exactly.
All right, Claudia, thank you
Thank
again
you.
for coming out here and presenting.